All right, we should be live on YouTube, so I'm going to go ahead and start the webinar. Okay.
Let me know when you're ready, please.
Absolutely. Okay, I'm going to stop sharing my screen. And Chair Khan, you can go ahead and call the meeting to order.
Perfect. Thank you, Melinda. So the first item obviously is calling the meeting to order and welcoming everybody who's on and those who couldn't make it too. So we'll call for the roll call. Leslie, are you on?
Yep, I'm ready. Commissioner Bobette Bond,
Here. Morning.
Commissioner Shulhagan Ralston. It's a longer
Here.
name now. Commissioner Lenitra Grady.
Any hands raised?
Good morning, present.
Good morning. Commissioner Flo Khan. I believe she said that she will be arriving late today. Chair Khan.
Present.
Commissioner Leanne McAllister.
I'm here. Good morning.
Commissioner Yarleni Roa Dugan.
Present.
Vice Chair Sandy Rubelid. I see you, Sandy, but I couldn't hear you.
Here.
Okay, your sound is really low. Commissioner Beth Slamowitz.
Present.
Commissioner Tiffany Tyler Garner.
Present. Good morning.
Good morning. Commissioner Mason Van Helling.
Good morning. This is Holly, Mason's assistant. He will be here in four or 5 minutes. He apologizes.
Okay, thanks, Holly. Commissioner Tyler Winkler.
Good morning, present.
Good morning. And for our non-voting members, we have Gina Castaneda, who's representing the Silver State Health Exchange this morning.
Good morning here.
Good morning. We have Laura Rich from PEB.
I am here.
We have Commissioner Richardson. She's joining via phone. Don't know if we can hear her. She was having trouble getting in, but she was in previously. And Commissioner Richard Whitley, or I should say Director Richard Whitley. I do not see him there yet. Okay.
So do we have
Mr.
a
Chair,
quorum?
yes, we do have a quorum.
Thank you, Leslie. Appreciate that. So we do have a quorum. We'll move forward. So the next item on the agenda number 3, we have introduction of our new and not so new person, new in a new position, I should say, is our new Commissioner, Sarah Ralston. So I would like to welcome her to the commission as a commissioner. Most of you who were part of the previous commission, I'm sure know her extremely well. So Sarah, welcome to the commission. You have anything to say to us?
No, I just thank you, Chair Khan, for the opportunity to reintroduce myself in this new role. I just want to say that I am honored to be a part of the conversation again in this new capacity and advocating on behalf of patients. So thanks for having me.
Thank you very much, Sarah. Welcome again. Our next item on the agenda number 4, is for public comment. And we...
Chair Khan.
Did I miss?
I apologize. Can you go back to agenda item number 2 for the approval of the minutes, please?
Or did I miss that? Yes, I did. Thank you. So do I have a motion to approve the minutes? Anybody approving the motion for the minutes?
Leanne McAllister, I approve. Motion.
Is there a second from someone?
I move we approve.
Okay, any opposed to approval?
Yeah, Chair Khan, just this is Sarah. I just want to abstain from this motion as I wasn't present at the last meeting. So if we can just put that on the record that I'd like to abstain from this. Thanks.
Yes, I appreciate that. Any opposed to approval of minutes? If none, the motion carries. So back to our agenda. Item number 4, public comment. Just anyone in the public comment, we'd like to have 3 minutes time for people in public comment to make sure everybody has an opportunity. So do we have anybody on the public comment side registered with us or with us now? Melinda, in the north or south?
Sure. So calling for public comment, please press *9 to raise your hand to provide public comment. Okay, I'm seeing none.
Okay, if you see none, and did we get any written comments to be incorporated?
We did not receive any written public comment. Thank you.
All right, okay. So hearing none, thank you. We'll move on to the next item, item number 5, discussion of funding request to the Peterson Millbank program for sustainable healthcare costs. I'll request Melinda to brief us all on this.
Absolutely. Just 1 second while we share the PowerPoint presentation. Thank you, Michael. All right. So as part of the Commission's collaboration with the Peterson Millbank Program for Sustainable Healthcare Costs, the Department of Health and Human Services Office of Analytics and the Public Employees Benefit Program would like to pursue the proposed funding request on behalf of the PPC. The Peterson Millbank program provides up to $200,000 to each participating state, but it's only available through the end of this calendar year because Nevada was accepted to this program at the start of 2021, and it's only a 2-year program. The proposals put forward by PEB and Office of Analytics present a great opportunity for Nevada to utilize this available funding with no cost to the state and provide the ability to complete additional phase 2 reports, as well as to include some sustainability training and continuity considerations. So we would like to give the PPC the opportunity to discuss this proposal prior to submittal to the Peterson Millbank for final approval. We anticipate it could take up to 1 month to receive final approval on this request, and we'll be sure to update the PPC during an appropriate public meeting on the status of this request as it moves forward. So as you can see, the funding request includes the following components. The Medicaid health conditions drill down report is estimated at $40,000. The PEB health conditions drill down report is estimated at $50,000. And training and capacity building is estimated at $14,068. And I just want to note that those drill down reports are not just the reports themselves, it's all the work that goes into that report and the data analysis and everything. So just wanted to open it up for any discussions on this request. Right, I'm hearing, oh, go ahead, Chair or Commissioner Cholhagi and Ralston, sorry.
No, I just think this is wonderful to see this work continue, and I really appreciate the transparency that you are sharing with us and with the public, showing the breakdown on how these funds are requested and utilized. And I'm not sure, I don't think this is an actionable item, but I just wanted to throw my support in and say that I appreciate the transparency and the request in moving forward.
Wonderful, thank you so much. And Commissioner Van Houweling, I see your hand up.
Yeah, good morning, everyone. Just looking at this slide, so there's no cost to the state. Is this part of our contractual arrangement as far as there's a grant within the contract that we would enter? And is there any obligation after the 2-year period if we were to request some of and draw on some of the funds for these particular items of drill down?
Thanks for the question. Great question. So there is no official grant document. It would just be a direct contact between Peterson Millbank and the vendor that's going to provide these services. So again, there's no grant and no ability to draw down on any of these funds after December of this year.
Hey, thank you.
I have a, Chairman Khan, I have a question. Can I?
Yes, please go ahead.
Thank you, Melinda. Thank you. Mason, I appreciate you raising this. So I thought this was approved last year, but maybe I missed the beginning of the explanation today. It's actually, I knew it was a 2-year process, but we have to get, are we extending it or do we just need another review?
So great question. So this is actually part of our 2-year program with the Peterson Millbank program. And it was an opportunity that was presented to us early on in the program. However, we didn't have the opportunity to request these funds at that point. And now that we're getting into the phase 2 reports, we're seeing that opportunity present itself and wanted to, responsibly take advantage of that funding availability to provide those.
Okay, thank you. I appreciate it. Good job on that. I just thought it was a duplication. I appreciate the explanation.
Absolutely. Thank you.
Any other comments before we move to the next item from any commissioner? Hearing none, Melinda, is that all you have on the subject?
That is all I have. Thank you, Chair Khan.
Wonderful. Thank you. Appreciate your input and keeping it brief in the interest of our time. So the next item on the agenda is the item number 6, the review and discussion of possible bill draft requests, including ranking of priorities. Now, this is always quite an involved process, as some of you recall from our previous experience. And we always solicit input from the commissioners prior to the meeting to understand their priorities that they think in their mind should be the priorities. So everybody has submitted their priorities that they think should be on. So we have gelled those priorities into the top 3 or so and narrow it down based on our deliberations. And I'll have Melinda kind of take it up from there, see what we got and received, and then we'll narrow down after a discussion as to how to get to hopefully 3 by a majority, if not consensus. Go ahead, Melinda.
Absolutely. Thank you, Chair Khan. Michael, could you please navigate to slide 7 for me, please?
So do you want to skip the next 3 slides?
Yeah. Thank you. All right. So to organize the wide variety of the BDR topics that were submitted by the commissioners, Baylor Health kindly offered their assistance in compiling a document strategizing the 17 potential BDR topics that were submitted, which should be found in the meeting materials today. This document was distributed to the commissioners along with a survey link, asking the commissioners to identify up to 5 topic areas that they liked. I do want to note a little caveat that in an effort to put every topic on more even footing, because not all commissioners submitted BDR topics, the commissioners were asked to choose up to 5 topics they liked that were not their own. To be compliant with open meeting law and our due diligence to the public, this agenda item today will only surround sharing the results of that survey, identifying the top 6 BDR topic areas, and allowing opportunity for discussion among the commissioners. Our discussion today is only meant to really give a strong basis for our continuing BDR discussion. I wanted to give you all time to be able to thoughtfully consider all top BDR topics that received a majority of interest from all commissioners, consider how we may want to change, add, or delete items from each area, some potential policy solutions to include, and to come to the next PPC meeting, all much better able to hold a very informed and thoughtful discussion on all proposed potential BPC BDR topic areas in this public forum. We also have an opportunity today to eliminate a topic or 2 if that is the consensus of the group. Additionally, if there is an important BDR topic that you feel is not appropriately represented as one of the top topic areas, please do note this during our discussion and consider voicing the BDR topic for the PPC to consider adding to our next meeting discussion. Please also be mindful not to bring too many added BDR topic ideas to the table at this juncture, as we are working quickly toward our BDR deadline this August. So as noted here, a web-based poll was issued to all commissioners. We had 11 or 92% of the PPC voting members respond. The following slides represent the 6 BDR topics that received the greatest number of responses during this poll. So I just want to pause there. Does anybody have any initial comments, questions, suggestions? Yes, Bobette, go ahead, please.
And I wrote you about this, so I know you're aware of my issue. I don't know, I have not talked to other commissioners about it. I have a real concern with you presenting 6 BDRs today when many of them were never presented to the commission at all. And I think that we had a process where people were asked to put their 3 BDRs into a previous meeting and go over them. And so those were presented by the commissioners, and some commissioners just didn't do that. And so then it looks to me when I saw the poll like other BDRs have been added but never discussed and never presented by the person that was putting them into the poll. And now we've already winnowed it down to 6 that are going to be presented to us today without a process where we hear about all of the new ones. And I think, I don't think we should do that. I think we should hold the 6 until we hear from all of them that have been presented and the people that are sponsoring them present them, so we have a better understanding where they're coming from.
So, Bobette, you bring up a good point. So the idea today is to discuss all of the above that you have outlined. This was a preliminary process that took place. And like you said, new ones have been added, and we should allocate some time for discussion and then finalize whether they fit into those 6 or they don't fit into those top 8 or whatever it might be. So,
but the 6 are already being presented here without us going back and doing the work to make the process even-handed.
and that's what I'm saying. So the new ones could be discussed, like you said, and become a part of these 6. Maybe the new one may become number 2 or number 3 or 4 based on the discussion. Isn't that what you're suggesting? Or I'm not understanding?
No, I think that we shouldn't have even voted until everybody understood all the bills. And
I don't recall us having added any. I think the ones that we sent out to you were all the ones that you guys had presented to you before.
I don't know if they are. We didn't have set 16 presented to us.
No,
Well-
this is Commissioner Winkler. There were new BDR topics amongst the 17 that we did not get to discuss as a board. And we were asked to narrow those down a little bit, but then we never went over the ones we narrowed down. There were new topics added. Like I think one of them is amongst these 6, but we never got to hear the discussion about it.
So, Bobette, what is thy pleasure? Should we be doing today? Would you want us to discuss those first before we make any progress?
Yeah, I think anything that was put into those BDRs should be discussed, and then we should be given a chance to revote based on what we hear today about all of them. I don't.
How many do we have that we think were added?
I'm not sure. I was surprised to see.
Melinda,
I was
do you have
surprised to see the list.
idea how many were added that were not discussed?
I
Go
do
ahead.
not have that information. I apologize. I do also see Commissioner Cholhagi and Ralston's hand raised.
Go
as
ahead. Go ahead, Sarah.
Thank you, Chair Khan. I actually, the only thing that I want to raise is that, you know, I was presented, so I don't want to come in because I didn't actually have time to do my own due diligence to look over the materials, what was being presented. And it does give me reason to pause when I hear the word vote on these measures, especially because I do think that Commissioner Bond is absolutely correct, and it's in the public's best interest to see a process, a deliberation, and a discussion on any of the measures that this commission puts forward. But it's my understanding that this was just a survey, meaning that you were soliciting just initial feedback for a kind of a baseline discussion, and we're like, these votes aren't something that is definitive in any manner. If that is the case, and if it is definitive, then I would like to either rescind my initial survey because I didn't have adequate time to go over it in depth. I just thought that, okay, here are some topics that we are going to be discussing for future deliberation, maybe after this meeting, after we hear about these, that we could come back and make more suggestions or discussion. So I'd like clarity on whether or not this is what the process here is, if this, what about the voting portion.
So yeah, let me try and clarify as best as I can. The idea has been to discuss all these recommendations, suggestions of priorities or BDRs. And in my way of thinking, it wasn't to sit down and vote on them today, but to open them up for discussion. And if there are new ones open, obviously they'll be open for discussion also. So after everybody has deliberated and that discussion, then if we are ready or narrow things down after public debate from everybody, then come back and look at the possibility of vote perhaps at the next time. So
Great.
the idea was to go over the discussion of the preliminary, and I underline the word preliminary priorities based on what was there, and then the additional ones that are added. And we should discuss perhaps the additional ones first and debate them, and then go back to the drawing board and narrow them down after all the input has been deliberated on. Does that make sense?
Yes, thank you so much, Chair Khan. And I just want to put on the record that I didn't have an opportunity to submit any ideas. So I was just weighing in on what was presented. So I would like to have an opportunity to also weigh in equally as a commissioner too. So that gives me more comfort in this process, and I appreciate it. And again, I would like to emphasize that I do think it is extremely important that the commission does have time to discuss and deliberate on any measures that they want to put forward, because I think, being a public body, we need to make sure that the public is adequately informed in all the discussions, and that there isn't, idea that's kind of rushed through without adequate time for the public to weigh in.
I agree with that. Babette, does that answer your concern?
No, I don't think we should be talking about 6 BDRs when there were 17 presented, and now when, good point from our new commissioner, she'd have 3 more, so we'd have 20. I don't think we should have 6 that we're discussing.
No, but as I mentioned earlier, maybe I didn't clarify. As I indicated, we should deliberate on all those that were presented and talked about in the 6, and there are additional ones that one could debate and deliberate on. And then hopefully we'll be able to accomplish something today in that deliberation and come back when we come back to the next meeting. And then there would be further inclusive of the additional ones, most of them at least in the prioritization process. Does that make sense, Babette? So we are just deliberating today.
Yes, Dr. Khan, I mean, I don't really mean to make this such a big deal, but I do think the process is important. These live on into the next 2 years of our lives, whatever makes it into this list. And it was complicated and it was hard to do the first time. And we ended up only getting through 2 of them. So I would like the process to be really a strong foundation from the beginning. I really think we should hear about any bills, including giving our new commissioner time to look at what she'd like to present, and hold this until we can look at what would be then 20 bills, hear about any that we didn't discuss, add to any that we didn't discuss, and then vote on whatever number it is that you've decided should be the number we vote on. I don't think we should be flagging 6 bills as priority bills today at all.
I agree with you. The process is crucial and very important. So that, having said that, I think going forward from here, we need to deliberate on all of that. So we're on the same page as a part of the process. So is the suggestion to table this till everybody has had a chance to look at the new ones and then deliberate and then vote? Is that?
Yeah, I would like to hear about the new ones, and I would actually like not to vote on any until I hear from every commissioner.
Yeah, as I said, we are not voting, obviously, today.
We already voted.
No, those were responses. Those were not votes.
Number of votes. votes is on the bullet point.
That's my
apologize.
mistake. This was a poll. It wasn't a vote. It was just a poll to pick up
Yeah.
where you guys had interest.
It's a poll. It's not a vote. That is correct. So if that helps understand. Any other commissioner has any thoughts to propose?
Commissioner Khan, not to get stuck on Commissioner Van Houweling here. Good morning. Not to get stuck on the number of 17 versus 20, but it looks like the team's done a really good job at least putting these in categories, whether it's coverage and transparency and access. So as we go through these, there may be opportunities to weave these in and combine them into one piece of legislation. So I'm kind of with the group. It's always good to just refresh and re-educate on what we've covered in the past, and then the ones that are new, we should go over those. And but I think let's not table anything today. Let's just keep having the discussion on what's new and how we can continue to refine these. And maybe it will change some of the way the voting members are leaning towards, so we have a consensus as much as possible.
Yeah, thanks, Commissioner Van Houweling. So I like to hear from the commissioners what's the appetite. Should we discuss and debate the new ones and then collectively put them into one bucket based on the initial poll and add another poll and put it all together? Is that the correct understanding? If not, please correct me. So it'll be just deliberation on the new ones. If somebody wants to redeliberate on the previous ones which were polled, I'm fine with that too, before anything goes to a vote. And I agree the process is important before we vote on anything.
Chair Khan, a few commissioners have their hands up.
Go ahead. So Melinda, can you recognize them? It's not on my screen.
Yes, please. Commissioner Winkler, go ahead.
So this is Commissioner Winkler. I would definitely like a chance for our newest member to review and be able to submit some ideas. We do have, I know we kind of narrowed it down a little bit, and we polled about interest in things. I saw that there was an appendix that would show us the survey results. I don't know if that's a part of our presentation today. Maybe we could just kind of review the things that have been submitted while we're all together. If anyone else would like to do that.
Thank you, Commissioner Winkler. Commissioner Cholhagi and Ralston, you also have your hand raised.
Yes, thank you for the time. So I have a couple of thoughts, and first, I guess I'm a little bit confused because I'm not sure if we haven't seen the poll results, and so just for clarity, I think what we're doing is we're discussing the surveying results of the commission that you had over the past week or two. I'm not sure what the timeline was from the last meeting. So we do go down the discussion. I mean, I'm interested in hearing about it, even at a preliminary level, to start a baseline discussion of kind of prioritizing the measures, because it does take time to have thoughtful deliberations on any of the measures that the commission is going to put forward. I just would like to have clarity that this is one, as Commissioner Bond indicated, not a definitive vote. This is not a prioritizing. This was just a preliminary baseline of surveying kind of interests. But we haven't seen the results. Is that correct? And so the process today is to share with the commission and the public the poll results. And I understand, I think, more at a more acute level, that we've got some open meeting law requirements that we're up against, in which you're not able to share the results with the commissions, behind, outside of a public meeting. So we wouldn't even be able to see the results or see what it is unless you share that with us today. Is that correct?
Yeah, I think your assessment is absolutely correct, Commissioner Ralston. So number one item, we need to share that. And then number two, if I hear correctly, everybody, that then we have to deliberate on everything that is presented, whether it is 17 or 20, the new ones for sure. And if everybody feels the previous ones submitted require further deliberation, do that also. And then perhaps narrow down to the top 3 or 5 or whatever it is, and then go to a debate and discussion before we vote on anything. I don't think we are anywhere close to voting on anything. Just trying to prioritize things so we narrow the discussion down eventually.
Correct, Chair Khan. Thank you for that. Again, this is a preliminary discussion.
Get the polling so that one can get started and then deliberate on the others and additional debate on the top ones presented in the poll.
Yes, and then also additionally, I see Commissioner Khan, you have your hand raised as well.
Thank you. And sorry I was late. So just Commissioner Khan for the record. I think I'm understanding this now. So we have the 17 proposals that were placed before us. We had just indicated in the previous poll kind of where our priorities lay in terms of establishing kind of like the top 6 that we would prioritize. And then we were going to have future discussion, I guess, around the priorities. But now, just so I'm understanding, so now we're going to open it back up and all 17 are going to be presented by the commissioners, some of which have already been presented on. But now we're going to present on all of them, or I guess, or maybe just the new ones that weren't spoken about or addressed previously. And then we'll go to another poll, I guess, or to prioritize, because we only can move forward three proposals, or 3 to 5, right? Is that correct? 3 to 5?
Only 3.
Only 3. Okay, so then we have to prioritize from there the 3, and then we'll have to spend some time on what those proposals actually look like. And we need to do this all by November. Is that correct?
We need to do it all by August.
August. Okay, thank you. Thank you. That just helps in terms of timeline. Okay, now I think I'm understanding where we are. So thank you.
Excellent. Thank you. And
Go ahead.
Commissioner,
Is there anybody else?
We've got some more hands raised, Chair Khan. Commissioner Bond, please go ahead.
Thank you. I just want to, I'm following you, Chairman Khan, and I think you captured all the pieces that we want to do. I'm just not sure that I totally agree with the order, but that's okay. I think that what you just laid out, though, does not make room for new proposals like what a new commissioner would add. And so there's no way today that we're going to have a way to prioritize 2 or 3 when we have at least 3 proposals completely missing. So I don't want to try to propose a priority setting today, but looking at these and then talking about the rest of the 17, and then finding a process where Commissioner Ralston can add hers before we vote is what I would support.
Yeah, Babette, I thought that's exactly what I said, but maybe in a different way. And that's my view. We have to deliberate on everything new and old. Look at the poll, and whatever the new ones have been proposed, look at them, including Chair Ralston's new suggestions potentially. And then after having deliberated on all of them, the new and old, then prioritize them, and then consider the voting after all of these deliberations have taken place in a public meeting. Does that capture what you're suggesting, Babette, and others are sort of suggesting? So we'll be just deliberating with an open debate on all the ones proposed, and Commissioner Ralston may have additional one to propose, which will be added to the bucket, obviously, and deliberated on with all of us, and then come to some narrowing down based on the consensus of inclusive 17 or 20.
And then if we're presenting 6 today, then how do the rest get presented?
They'll get presented at another meeting, Babette.
Okay.
Yes, it'll
right.
have to be in another meeting.
Sorry, I thought we would get to see the survey results for everything.
No, we will see them, but the deliberation, I don't know how much deliberation we will be able to accomplish, but deliberation has to be thorough, which it may include today and some next meeting.
Correct. So with that, I would like to move on to just at least presenting these topics in a preliminary discussion with the commissioners, if I could. And then we can, as we've mentioned, present the rest of them at another meeting.
So at least let's get started with what we have and including the other ones that were proposed but didn't come into the polling priority. Whatever that number is, whether it is 17 or 20, and keep in mind, one commissioner may have additional one proposals to add to potentially, which is Commissioner Ralston.
Yes, absolutely.
So
All right.
go ahead.
Thank you, Chair Khan. With that, could you go to the next slide, please, Michael? So this proposal received 7 responses. This proposal represents a compilation of potential BDR ideas from PPC commissioners regarding access to and interoperability of electronic medical records. A couple of things I wanted to note here initially is that AB 348 that was passed last session did require the PPC to develop a plan to address a lot of these topics. And a planning team has been assembled to address this plan. And I can provide you updates accordingly as I meet with that planning team and we embark on some of those topics. Additionally, as noted in item B, the Office of Health Information Technology does not exist due to state budget constraints and the sunsetting of the high-tech specific federal funding. The Division of Healthcare Finance and Policy will not be establishing an Office of Health Information Technology as was previously planned. Current and future health information technology efforts, to the extent possible, will be absorbed by the existing resources within the Division of Healthcare Financing Policy Information Services Office with a focus on the Medicaid enterprise systems. And as you all review this list, some of these items were addressed already, as I mentioned, through AB 348 or SB 40, which was the all payer claims database bill that we had brought forward last session. And just again, wanted to note, this is a discussion item at this point and just wanted to open it for discussion. I see Commissioner McAllister, you have your hand raised.
Thank you. So if possible, so right now we have WebIZ in the state of Nevada, and it's wonderful when entities enter in the information into the system, but there's no legal requirement to do so. So if we are going to move forward with a bill like this, adding a line, ensuring that healthcare entities that have generated the type of medical records that we are talking about, that it's an obligation either through state licensing or some other mechanism that they can't just not do it.
Thank you for that. And then I see Michael Bailey, you have your hand raised as well.
Yes, I want to apologize to the commissioners for my poor math skills. So there were 11 responses, so 7 of 11 would be 64%, not 70%. So I apologize for this slide and other slides that might have the same mathematical errors.
Thank you, Michael. Commissioner Ralston, please go ahead.
Oh, thanks. I'm just looking into this, so I'm sure I will look over a lot of these measures and discussions and have a little bit more to weigh in for next meeting. But just glancing over this, I think it's a great discussion. I would also maybe add unless there's an objection from any of the commissioners and I'm missing something, but also adding to this, codifying the interoperability final rule, the federal rule, into Nevada state law. In addition to this, I just think that we don't want any unintended consequences if you're moving forward with a measure like this. And I just think it would be great for continuity between the state and federal government. So if we're going to have this discussion, I'd also like to add in codifying the interoperability final ruling as well. I just think it makes sense and it would fit within this. So I like this. I just think maybe add a little bit more. So that's just my thoughts. And I just wanted to throw it out there now because I'll likely weigh in for the next meeting, but that's at least where I'm thinking about for this proposal.
Excellent. Thank you so much. Commissioner Bond, please go ahead.
Thank you. I just would like us to consider, maybe it can't be part of the BDR, but I would like us to consider the information you just shared verbally, that there is no Office of Health Information Technology at this time, and that's a flaw in our structure. So I'm not sure what we can do to codify that, or how to support funding the kinds of interoperability support we need to be able to make this work. I feel like this bill would help two segments, doctors' offices, small doctors' offices that don't have a lot of resources or time to link their medical record to other medical records, but the technology now exists to make that really easy. It's not like it was 10 years ago. You could link Epic to like our Athena medical record with a little work. So I would like us to be able to have the support to do that. And then I think the other important part that this provides is all the patient access, which is really not available yet in EMRs, that I think is worthy of the state's efforts. But we would need a central home for that in the Office of Information Technology. And so I think that we will need to figure out some resources.
Thank you, Commissioner. And Commissioner Khan, I see you have your hand raised.
Yes, thank you. Just two questions. The first is, could someone just briefly kind of describe what the federal interoperability rule does or says? That would be one. And then the second would be cost. Do we have a cost estimate of what this could entail to the state?
So for that, I do not have a cost estimate. I don't know, Vice Chair Rubila, do you potentially have some information on that?
Sure. I think if you look at, can you hear me, first of all? Okay. I was having difficulties earlier. So I think if you look at item E here, that kind of sums it up. So at the federal level, insurers that are regulated by CMS are required to give patients access to their claims data, as well as a provider directory using application programming interfaces that are standard. So what that means is they can go to the App Store and download an app, and that app will help them communicate with whatever carrier to get their information while they're at the doctor's office using their smartphone. So Medicaid is compliant with this rule as of July of last year. We also have an app that members are able to use to download and get their claims formulary information, as well as a provider directory. What I will say is that Nevada does not have a robust health information exchange or a clinical data repository. And so while the rule does require that you give patients access to their clinical data, if the state doesn't own or have control of that data, they're not required to do that. So that's kind of a high level overview. Happy to answer any questions, but I think the value of this here would be for those insurers that are not regulated by the federal government to be required to do the same. I don't know if that's helpful or if anyone has questions.
Thank you. That's very helpful. Thank you. And Sandy, do you have any cost estimates? Like, do you?
So, I mean, back to the Office of Health Information Technology, that several years ago, the plan was to really beef up and staff up an office. The purpose of the office isn't to provide the solution. It's, you know, a lot of times it provides regulation, oversight, and funding opportunities. As was stated earlier, the high-tech funding has sunsetted. That funding was really geared at getting providers to adopt electronic health records. That is no longer the focus. That funding has been sunsetted. Like I said, the new funding stream really is focused on Medicaid systems and what benefits could be brought to the Medicaid program, because it is federal Medicaid funded. So I don't know if that's helpful either, but I mean, if the goal is to stand up a state-owned and run health information exchange, that's not cheap and it takes a lot of resources. So I don't have an exact dollar amount, but I can say that as a state, Nevada is not in a position, we would have to build it from the ground up at this point. You know, we just don't have the infrastructure.
Okay, thank you.
Sure.
And Commissioner Bond, I see you have your hand raised.
I do, but I think Commissioner McAllister did first.
Oh, thank you. I'll just be brief. I think for the record, I don't think I would vote for this bill going forward, because as much as I like the ideal of it existing, I don't think it does a lot for us to control spending of healthcare dollars here in the state.
Thank you, Commissioner. Commissioner Bond, please go ahead.
Thank you. I just wanted to respond to something that I heard Commissioner Rabala say about the role of the state in an HIE. I think that this bill wouldn't have to address the lack of HIE at all. I almost feel like the new interoperability world is one where one funnel of one pipeline of one HIE is almost obsolete. I feel like more this idea that we could connect doctors directly with each other and focus on patient access doesn't require an HIE. So I just wanted to make sure I was able to say, I don't think the dialogue that I'm hearing is that we need a state-owned HIE, but I do think the state should control the HIT information that exists if there is a system.
Thank you, Commissioner. Commissioner Van Helling?
Hi, good morning. Just to kind of weigh in, because I supported some of this information about interoperability, and just to the point that Commissioner McAllister and not getting controversial on it, it may not control the spin, but it will control waste and duplication and sharing information. Because I can tell you from our own hospital system, patients do visit very frequently within other systems or other offices, and if you can drive out duplicate MRIs or duplicate labs that were just done the previous day, I think it would help control cost and drive out duplicative tests, and which will also speed up diagnosis and outcomes and quality. So I know looking at the spend dollars, but I think just using resources and using our resources better in a much better allocated way, with having information from other facilities, other healthcare providers, could have improved outcomes and better patient satisfaction.
Thank you, Commissioner. Commissioner Khan, please go ahead.
Thank you. I agree with that. I do think that there's value in the fact that if you can coordinate care better, and it does eliminate waste, but it also improves the quality of care for the patient. Particularly when you're talking about like mental health and some of these other, kind of costly conditions. So I do think there's value in the proposal, in that it would have significant benefit for the patients. I guess the other question that I had with respect to what are the requirements of the federal government on interoperability now? And if there are requirements that the feds are going to put onto the state, then there should be conformity there. I think that is important. And it does eliminate duplication and other things that can cost the healthcare system money.
Thank you, Commissioner. Is there any other discussion on this item? All right, hearing none at this point, we'll move forward to the next item to keep the discussion going. So this next proposal received 6 responses and is a proposal to codify the Nevada Healthcare Cost Growth Benchmark Program set forth in Executive Order 2021-29, and includes a requirement to measure and report on primary care spending. So with that, I just wanted to open this item up for discussion.
I didn't, I'm sorry, I'm talking.
Go ahead, Commissioner Bond.
Gosh, so inappropriate. I'm sorry, I've done that twice. I think that this would be great progress. I think that the previous executive director who's here with us, Commissioner Ralston, and the work that's been done by the state and the executive order signed by the governor, those are all getting us in a position to actually do something about this. But since it's not codified, I think it should be in statute so that we're moving forward.
Thank you, Commissioner. Appreciate that. Commissioner Ralston, please go ahead.
Yes, and I just want to weigh in, and if it's not obvious, that I fully support this measure. I think it's continuity of the work that we have done. It really is important for patients, access to care going forward, long term, and this has my support 100%. As I'm sure, as Commissioner Bond indicated, that this is also in alignment with the governor's office, and so I think that this should move forward 100%.
Thank you for your comments. Additionally, seeing some comments in the chat, Commissioner Roe Dugan, Commissioner McAllister, and Commissioner Tyler Garner fully support as well. Commissioner Van Houweling agrees with Commissioner Flocon that we need to review the federal regs on interoperability and cross-reference to ensure support and reduce conflict. So appreciate those comments as well, commissioners. Any additional comments on this item? Okay, we'll move forward to the next one. So this third proposal also received 6 responses and is a proposal regarding mental and behavioral health provider workforce development to require that health carriers in the state of Nevada have sufficient availability of and access to mental and behavioral health professionals in urban and rural areas throughout rural Nevada. So there are 3 areas in which this could be addressed. The first would be to identify and address mental health focused physician, nursing, and other licensed mental and behavioral health professional shortages. Second would be to identify and address behavioral health focused physician, nursing, and other licensed mental and behavioral health professional shortages within healthcare networks to improve access for patients in need. And third would be to expand the types of health carriers for whom these requirements will apply. And with that, I will go ahead and open this item for discussion. And Commissioner Winkler, please go ahead.
Oh, thank you. So this was one of the new topics that we hadn't had presented, I believe, and I would like to hear more about this because I do think it has a lot of interesting points, especially the requiring health carriers to have sufficient availability. I'd be really interested in what kind of ways that could be done. Is it possible the commissioner who submitted this could give more details?
Excellent. Can we please have the commissioner who would like to address? Please go ahead.
Good morning, everyone. That would be me, Commissioner Van Houweling. Thank you, Commissioner Winkler, for asking for a little bit more information. And just going to go off my notes to make sure I capture everything. But it's really around identifying, addressing mental health focused physicians, nursing, other licensed mental health and behavioral professional shortages, and to really support the development and facilitate improvements to the licensure attainment process. Also, looking at some of the healthcare networks to improve access for some of those patients in need of mental health services. And then also expand the types of healthcare carriers for whom these requirements would apply. And then just identifying ways to maximize, again, back to healthcare interoperability. So there's a way to ensure that this is layered in to some of our discussions and sharing of information in regards to electronic health record to really improve efficiency and quality for patients in this particular category of mental health. So hopefully that helps, Commissioner Winkler. I know very broad and we can always refine, and I'm certainly not a mental health or behavioral health provider expert, but I know that we have others, and also the strength of the state is very well versed in this as well, so we can lean on them for their expertise.
Thank you, Commissioner Van Houweling. Sorry to put you on the spot with that one. You did great.
I'm always ready.
Perfect. Any other discussion?
This is Commissioner Winkler again. I guess I'm the thing I'm most interested in is that, what does that requirement look like, especially for private carrier payers. Yeah, I'd be, or how would that be enforceable? I guess it makes a little bit more sense for our public plans and things. But I think that's that's a novel idea to approach this, because I think a lot of even the mental health care providers we have just stopped taking a lot of insurances. And maybe that's a way to address that. If we can talk to plans and say, well, then you need to increase what you're paying for a service or whatever it might be to get to the sufficient availability. I'd be interested in what those options would look like.
Yeah, Commissioner Winkler, and I think also just looking at our current resources, whether it's in regards to facilities and access to those that may or may not be in network, and maybe along the lines of what you're thinking of maybe it's not a bed shortage, but it's more of an access via the payers, and a topic that at some point maybe have a discussion on any willing providers. We're not an any willing provider state, but down the road, it's always up for debate and topic. There's both sides to that argument, but ensuring that looking at our current resources and is it a resource issue? Is it a reimbursement issue or access based off of current reimbursement rates, and in particular to the private side of things, so commercial. So just obviously we've talked about mental and behavioral health from the beginning, and just trying to layer in the workforce development around this as well, and doing a little bit more support from us. But since I've been on the PPC 1.0, this was really the big topic that came out of that priorities. So I figured we try to address it this legislative session. But open to any comments and very willing to have addition to beef this up.
Thank you, Commissioner Van Helling. Commissioner Khan, you have your hand raised. Please go ahead.
Yes, thank you. Just wanting to follow up on that and see kind of as we progressed in the telehealth space last session, are there ways that you can improve, or are you aware of like opportunities to increase licensing of these to make it easier, not easier in the sense like less qualifications, but the process easier for someone to apply and become one of these professionals, licensed professionals? I agree the reimbursement is probably always an issue, but encouraging more students, maybe opening up opportunities for more students to go into these fields, if that's a possibility and needed. And then also, obviously network adequacy, making sure that from coverage areas that we have sufficient providers of these types in throughout the state, particularly in those rural areas, and making sure that our from an insurance perspective that we do have adequacy within those kind of deserts, if you will.
So this is Dr. Khan. So those are important questions you raised. The concern I have on those lines is that availability of providers, if something is going to be mandated, semi-mandated, or expected, there aren't enough mental health providers in the state. The shortage is a lot worse than the general shortage of physicians. But one has to start somewhere and hope for the best, because it's not just the rural area availability, it's the suburban and some of the urban areas also. Even in Las Vegas, mental health provider services sometimes can have waiting periods of 3 months to get in to see somebody. So telehealth will help the rural areas a little bit, perhaps. Telehealth may be helpful in the urban areas, but to have physicians available to do telehealth also, where the time is limited, that's going to be a challenge. So that has to be kept in mind before anything gets into the legislative expected requirements, rather.
Thank you, Chair Khan. I do see that we have Commissioner McAllister. You have your hand raised as well.
Thank you. If available, I would be very curious to see examples of other state laws that have addressed this issue and a review of how long they've been in place and what kind of impact they've had. Absolutely an important topic, but it's hard for me to make this a top priority for us when it's not something that when there are other examples of state laws that have had more immediate risk impacts on the cost of healthcare spending in the state.
Thank you, Commissioner. And Commissioner Bond, please go ahead.
Thank you. I think this is a good example of why we wanted to hear about all these proposals before we prioritize, because it might change some prioritization. Thank you, Commissioner Van Hollen, for going through this. I really appreciate it. I think that what would be really helpful is to learn more about the current licensing process, because I know all these boards are really complicated, and I know that there have been in the past efforts to try to address some of the board delays or board concerns, and parity for licensed professionals would be wonderful for us to look at. I'm a little concerned about things that sound like a mandate, and I'm a little concerned about things, as soon as you say any willing provider, I get a little nervous. But I think the licensing components are definitely a barrier we should look at.
It was hard to come out of my mouth, I'll bet, so I know. but I think, just looking at, and I agree, just expediting licensure and credentialing. And we talked about that across the board in the medical community, whether it's the medical board, dental board, and others. So any way that we can speed that up, that just brings doctors and nurses to the state quicker.
Thank you. And Laura Rich, please go ahead.
Go ahead.
I just wanted to provide some insight, because PEB actually went through something that is pertinent to this conversation. We switched networks last year, and in that process, we found that our new network had a pretty significant shortage of mental and behavioral health professionals that were in network. And so recognizing this, in fact, I had a lot of members come to me, and also a lot of healthcare providers as well, who said, hey, we're not part of your network anymore, and we're losing a lot of your state employees. We can't offer them in-network services anymore. And so I directed the network to engage with these professionals or these providers and contract with them. But in that process, because of that, they didn't necessarily contract with them at the same rate that they would have contracted prior to that. And so there's a potential here, because there's such a provider shortage, that there's a potential to increase costs, because those networks they're not going to be able to contract with them at the lower cost that they're attempting to, right? So they're not part of that network to begin with, because those providers are saying, look, we're not going to participate in your network because you guys don't pay enough. And so they're having to come to the table with higher reimbursement rates, right? So I just wanted to illustrate that, because that provider shortage is resulting in those higher costs, at least to PEP, because of that.
So this is Dr. Khan, if I may. So there are a couple of important points raised. One which was just very clearly narrated about the availability of physicians. And I think Commissioner Whitley is on, and we are facing a serious challenge with Medicaid patients, whether it's managed Medicaid or other Medicaid, because of the non-availability of providers who do not want to sign up for the rate that the state is willing to pay. And the mental health challenges are a lot higher in the population that is on a Medicaid program. So that's a separate issue, separate discussion, budget, et cetera, availability of money. So that in itself is a problem. Regarding the licensure, I know it keeps coming up. I've served on the board for 8 years on the medical licensing board. There are two components so that everybody understands. The medical licensing board is very adequately staffed, to the best of my knowledge. The challenge comes in, and they expect the credentials come to them directly from the source, wherever the doctor did the residency, medical school, etc. And that takes a lot of time to mail somebody or email it. Sometimes they want originals, sometimes they want notarized copies. And so the physician is going back and forth trying to provide that, and that takes a very long time. That is something perhaps one can look at. like it was alluded to, if they have gone through that process in another state and the state is willing to share their data, reciprocity of license in some areas would be of help to perhaps get the physicians to come to this state. Otherwise, we will not make progress in the physician availability. The board itself doesn't drag its feet, but the rules that are in place for them to vet a physician, and Babette is here with the managed care. Managed care also does a lot of vetting, but somehow things move there a little quicker than they do at the state board level. But the board does its best to try to expedite, but physician cooperation is needed to get the paperwork to them in a timely manner.
Thank you, Chair Khan. I did want to note that Commissioner Slamowitz did note in the chat, wondering if this would be better served as a legislative study to understand where the deficits are in the state and some of the roadblocks causing the state shortage in providers and access.
I think many studies have been done. There was a committee, a commission or a board or whatever, but I don't remember the title, created by Governor Gwynn at one time. I know that because Anwar shared that access issues, and there's a whole report of challenges to access to healthcare. It was meant to study that. It's a little old, but not a whole lot has changed in the main headlines of that board's study. So it may be worthwhile getting access to that, at least as a starting point.
Thank you, Chair. Commissioner Van Houweling, please go ahead.
Good morning, and I'm sorry, I've been told that there's a ringing noise when I talk, so I'll talk quick. Chair Khan, is there any regards in your expertise on the medical board? Often when I've talked to medical board members, also when they talk about U.S. graduates versus foreign medical graduates, is that time frame and delay just getting information from those foreign schools, or is it a different vetting out process that often delays things? Because I know we've seen some licenses get approved very quickly in the state, and it's typically around the U.S. grads, but foreign medical grads. Is that something that we could look at as well?
Yes, to a great extent. The time factor is important. They have to communicate with the medical school where the physician graduated, and you know how that goes, for FedEx, etc., to send notarized copies of their graduation, their report cards, etc., etc., etc. That is a tremendous setback. Those that go quicker are the physicians who are coming out of residency. It's easy to vet them because they do not have too much of a paper trail. It's their medical school within the US that quickly sends the papers. It's their residency chairman that sends the papers, and that's about it. So those go very quickly. Those who have been in practice a long time, they have a lot of paperwork to submit. Where did the practice? They don't want any gaps in their practices. They want every single year accounted for, and that can take forever. But there has to be a better process of getting the international medical graduates documentation in a more efficient manner.
Thank you, Chair Khan. Commissioner Bond, please go ahead.
Chair Khan, thank you. I think I just wanted to amplify that because we do a lot of credentialing of providers, and we need a process where we can introduce licensing reciprocity wherever we can. So I mean, this conversation is making me push into reciprocity research, because we did that with dentists long ago and it was controversial, but then it worked. And to your point, if you're a new graduate, your record's really new, right? It's really slim. It's easy to get through the materials. But if you've been in practice for a really long time, it can be very hard to get through the steps in Nevada. And I know a lot of people have looked at it before, but we haven't made progress. So if there was a reciprocity focus, I would be really supportive of that.
Yeah, and Bombette, you bring up, this has been debated many times, as you know, in various forums. And I think it's doable if the other states are willing to share, which in my understanding, they are all willing to share, but we are not willing to accept somebody else's vetting. And that's a challenge. And if that can be changed in a reasonable manner where we do not compromise the quality of credentialing at the same time, I believe very strongly it's doable. It'll make life a little easier to get more physicians for everybody, for managed care, for private sector, for hospitals, medical school, etc.
Thank you.
Well, comments in the interest of time, we need to keep moving.
Yes, just one more comment from Commissioner Winkler.
Real briefly, I also wanted to support looking into reciprocity as a possible solution. As I was researching for these BDRs, I think what we've seen over the public health emergency has been a little bit more loosening of those rules, and perhaps we can take what we've learned from that. When we've been showing reciprocity for healthcare providers, has it caused any great issues? Has it worked out really well? Perhaps pandemic could be useful in that way.
Yeah, that makes sense to look at that closely. Any other comments from any commissioners?
Just really quickly, Commissioner Ralston.
Yeah, sorry, I don't want to take up too much more time on this item, but I just can't help but listen to what Laura Rich was saying earlier, and what resonated with me as a patient advocate is seeing the unintended consequences that something like this could have on the cost for patients. I do think that I agree with maybe having a deeper discussion about reciprocity, and also when we go back to the discussion on the benchmarking work that the state is doing, I think, having maybe a discussion about workforce stability as we're collecting healthcare spending data. And so that way we can actually get a measurement. I think we will know more about our state needs when we are collecting that data and analyzing it, but also maybe putting in a provision ensuring that there is some sort of workforce stability, because I think what we could see is that some states, in order to reduce costs, may take that to workforce. So there's just a couple of things. It's a little bit separate from this, but that made me also think about unintended consequences as well. So just wanted to throw that out there.
Yeah, thank you, Commissioner Ralston. So I'm just looking at the clock here. We have another major subject allocated an hour of discussion. So how far are we in our BDRs, Melinda?
So we have 3 more to go over, and we have about, I would say, 20 minutes to get through those 3.
Right, if we can try to do that, and then there are newer ones that we still have to discuss. We'll have to table them for the next meeting to carry the discussion to be carried on the additional potential BDRs that are coming through or have come through.
Yes.
So I think wrap it up in 20 minutes so that we stay on time. As you know, I keep reminding our fellow commissioners that everybody is busy, and I hate to go beyond the allocated time for people who are volunteering.
Absolutely. Just really quickly, Commissioner Khan, would you mind just quick?
Real quick, I would just say, I think as we look at all of these proposals, it's important to note that sometimes we may have to spend money up front to save the system in the long run. And I do think that there is value in doing that, particularly as we talk about preventative things that we can help reduce, or even if we're paying up front or on the licensing stuff, if we can identify more more providers so that we don't have this shortage, so that they can't increase the cost because, we've got more out there. I think we should definitely be focused on those types of things. So I understand the cost up front, but I think there's value at the end sometimes for some of these things.
Thank you, Commissioner. Appreciate those comments. And Michael, if you could please advance the slide. All right, so this 4th proposal received 5 responses and is a proposal to expand Medicaid coverage to residents regardless of immigration status through submitting a 1332 waiver request and to develop new state funding mechanisms permitting Medicaid coverage. So just wanted to open this item up for discussion.
Any commissioner with hands up?
Looks like we have Commissioner Van Helling.
Yeah, good morning. And I'll just question, do we know the population impact? I'm just reflecting on the very informative presentation we had last PPC with Director Whitley and his staff on the current Medicaid status and metrics. Do we have an idea on, and I think what stood out to me the most was 1 in 4 Nevadans were on some type of Medicaid product. where would this put us in the grand scheme of things in regards to expanding this based on regardless of immigration status? And then I know, here even at UMC, placing patients and having people accept patients that don't have a payer source has been very challenging. And some of it's due to their immigration status, not having the ability to qualify for any type of assistance. So have we put a number to this particular suggestion just for impact but also financial impact to the state's budget?
Commissioner Whitley, you have any response to that?
I don't believe Commissioner Whitley is with us today.
So to follow up, if I may, on Commissioner Van Holling's point, this is a huge, huge challenge in the state. It falls back on budgeting. And my view is a little bit more aggressive, is that if the legislature makes up its mind to address something, there is always ways and means to do that. If we can find hundreds of millions of dollars for education, which is crucial and important, healthcare to me is just as important, if not more. And the state needs to figure out a way of finding the budget resources so that healthcare access becomes a little bit more affordable and doable from the provider point of view, and more importantly, from the patient's point of view, to have access to care. We have backlog every day where nobody wants to take Medicaid patients in the extended care facilities because the payment is low. And Richard Whitley, Commissioner Whitley, is very well aware. I talk to him off and on this subject. Not much they can do as staff between the governor's office and the legislature if they are hopefully willing to look at this healthcare issue of challenges, which they are keenly interested to help and resolve. And I know that firsthand. Then budget is the area where one has to start and find the source of money to address that, to provide better access to what Commissioner Van Holling is alluding to. It's not just the residents and citizens, but also these non-registered foreign visitors and others who come here with no insurance, especially those who are living here for years and have no source because they're not immigrants. And that really drains the resources of the hospitals at the cost of resources for different provider patients. So I don't want to get started on because this is my pet peeve and we'll save it for another day.
Thank you, Chair Khan. Commissioner Winkler, please go ahead.
So I think this topic definitely has a lot of interest from many of us from many different angles. And I think this is probably something that needs to be developed a lot more, especially with more information, seeing what other states have been doing with their 1332 requests, waiver requests, but and just getting more information to understanding the impact of this, because this is definitely something I personally would want to help to develop and find something that we could submit that addresses this issue, that access.
Thank you, Commissioner. Commissioner Van Helling, please go ahead.
I think I never lowered my hand, but to Commissioner Winkler's point, and I think, stepping back and looking at the care of patients, regardless of their immigration status, there's costs associated to that. So I'm having, I think, Commissioner Winkler's point of patients are getting cared for in our community, sometimes not always in the best setting or the most appropriate setting, and often in the emergency room setting, and having an open dialogue on appropriateness of care. But I think the state really needs to weigh in on, first of all, is this something that the state could afford, and what that impact is. And we know that there are other states that have done this. But looking at the other side of the coin is the cost, the care is being delivered. We know that. And is there a better way to do it in our state that makes it more efficient and uses our resources better, and keeps patients not using the emergency room as their first point of primary care or any type of care. So but Commissioner Winkler, I think certainly we need to dive into it and see what the impact is. But I think at the end of the day, the Director of Health and Human Services really needs to help guide us through this particular one, because it is a more and more a popular topic to have discussions on.
Thank you, Commissioner Manalik. Anybody else raising their hands in the interest of time?
Yes, Commissioner McAllister, please go ahead.
I put in the chat a link to yesterday's Seattle Times article about Washington State making this step, if anyone's interested to take a look.
Yeah, I would take a look. Thanks for letting me know.
Thank you, Commissioner. With that, I'm going to, Bobette, if you could really quickly, I apologize.
Really quickly, I thank you. I think the only thing I'd like to just get on the record is this alternative to covering the uninsured seems like it's expensive, but it would be a more sound approach than what they've done with the public option if we had to make a choice. I just wanted to add that comparison to the public option that's now moving through the Nevada legislature and the state. Thanks.
Thank you, Commissioner. All right, if we could please advance the slides. So this fifth proposal also received 5 responses and is a proposal to address the housing crisis through multiple means, such as through Medicaid waivers, targeted legislation, infrastructure funding, and adoption of affordable housing policies. This proposal also includes establishment of rent controls, develop permanent supportive housing plans, and pursue Medicaid state plan waiver authorities to add non-clinical services to Medicaid benefit package. And just wanted to open this item up for discussion.
So quick question, is our attorney present? The AG's office? Well, I'll take it offline.
I apologize. What was your question?
My question is that this particular subject matter, does it come under our domain as a commission, or is going a bit too far out?
As far as the housing crisis?
Right.
That's not really a legal question. But being the PPC, I would think that would be a little far afield of what the commission's mission is.
Yeah, that's my question. Under the charter of this commission, does this subject matter in a reasonable thought process come under our domain?
Based upon my understanding of the commission's mission and charter, I would think that it would be a bit outside.
Okay, thank you. Any other comments from other commissioners on this, having heard what the attorney's thought process is?
Commissioner Winkler, please go ahead.
So I might be a little biased because this was something that I submitted, but I think it's a very clear link between a patient's housing situation and their overall health. People can't get better if they don't have a home to go to. And of course, there's the mental health issues that come from not having secure housing or dealing with, things that are too expensive, having to put shelter over getting medical care. These are definitely issues that affect health and affect affordability, quality, access, all of those things. I definitely think this is something that the PPC should consider.
So I think what we'll do is any other discussion on this one, when we get down to eventual voting at some point in the next meetings, it'll take its own position based on how everybody else thinks. Any other comments on this?
Seeing none, I'm gonna, in the interest of time, I'm going to move to the last slide on this. So this sixth and final proposal also received 5 responses and is a proposal to improve access to telehealth. Specifically, this is to codify the current COVID-19 related telemedicine provisions, ensure there is sufficient access to technology and connectivity to support telemedicine in Nevada, address parity of payment, and address licensure and adequacy of network issues. And I believe that SB5 did address some of these issues, but some of those might sunset either in June 2023 or 1 year after the end of the public health emergency. And just looking, if anybody has any information on that, please speak now.
Anyone raising a hand?
Commissioner Ralston, please go ahead.
Yeah, I just want to say that that is accurate, that the expansion of the payment parity portion does expire in June of 2023.
Excellent. Thank you for that confirmation. And Commissioner Bond?
I think that I would really, as one of the first wave of commissioners, I would really like us to work on other topics. This worked its way all the way through the legislative process and was changed, and it sunsetted because it was controversial. And I think that the idea that it would be just as much money to have a visit virtually as it would to go into a doctor's office for every kind of care is controversial. I think that there was an interest in focusing on just behavioral health going that way because behavioral health works so well through telehealth. But that's just my 2 cents on this issue.
Any other comments so that we can move along?
I have a quick comment just or a question on that. In terms of, do we have any data or any kind of intelligence based on it being SB5 taking effect that we've increased the number of providers that have become available and that we're seeing any kind of changes in terms of access improvement?
I may just briefly answer that. My understanding is not necessarily. The bottom line is that not every doctor's office has been able to put together the electronic processes to conduct a reasonable, decent telemedicine patient care coordination. Number two, a lot of the senior population are electronically challenged and they're having problem accessing telehealth. They'd rather see the patient physician in person. And during COVID, it made sense. But now a lot of them want to go and see the physician. And some of them come in so excited that they were able to finally see the physician in person. So there's no genuine replacement. There are challenges with the telehealth processes. In rural areas, it's a little different. But other than that, there is a challenge in trying to stick with the telehealth medicine. Any other comments?
I'm not seeing any. Thank you, Chair Khan.
Okay, so we go to the, are we done with the 6? We have still others to talk about and discuss at the next meeting and some more discussion on these.
Correct.
Okay, so we can move on to.
I think we have a commissioner that has a question.
Okay.
Commissioner Tyler Garner, please go ahead.
Thank you. In the absence of ensuring access to telehealth, do we have any thoughts about how we could ensure a responsive approach to our rural health needs?
So I may be able to comment generally, not specifically at this point, is the rural access has been a challenge forever and has been discussed in every board or commission that was ever created, to my knowledge, how to improve that. And it has been debated at length, and there are no easy, good answers. Telemedicine helped a little bit, but then again, it's the same challenge. People living in rural areas are electronically challenged, and they're having a problem getting to people on telemedicine. And then the other challenges, they don't have physicians in their community to go and see, and the long drive. So I don't want to dwell on the details of it, but it has been discussed in multiple boards and commissions. Some of them I was on, and there's no good, decent answer. You just can't find providers to go and base there or to do 2 or 3 telemedicine calls in a day and be paid by somebody as a salary to do it for them for rural areas. So it's not cost effective for the providers either. Any other? Go ahead.
Commissioner Tyler Garner, did you have any additional comments, questions?
Just a thought. I'll just speak for myself and say that I could benefit from some additional context, particularly if we aren't supporting access to telehealth. What approaches would be applied, and then the costs associated with each, like some type of cost benefit analysis.
So we may need some homework done on that. That's a good point. So Melinda, could you please take note to get some more information?
Yes, absolutely, Chair Khan. I'm on it. And then additionally, I did want to note there is a comment in the chat from Commissioner Slimowitz, agrees that social determinants of health are the foundations of a health society. And Commissioner Ralston, did you have a comment?
No, I just wanted to emphasize that, I mean, the provision that is expiring from the telehealth measure that was passed is really just alluded to the payment parity portion. It does not prevent any drop off in access to care. Providers and patients can still utilize telehealth. We actually have, I think, some of the strongest telehealth regulations or laws in the nation. And I think Nevada should be very, very proud of that. It is just the portion of the payment parity part that will be sunsetted, but the access will still be there. It's really, I don't know, I think providers are better equipped to talk about this, but I really think it's more of a discussion on how the providers choose to utilize telehealth going forward with their patients and whether they see the value and, you know, continuously providing it to their patients.
Thank you for that clarification, Commissioner. Commissioner Bond, I see you have your hand raised.
Yeah, I'm just dittoing that. I think it's that third bullet, address parity of payment. That was what was an issue, and that's what sunsets because it was an issue in the legislature. But I don't think anybody in the board at that time or in the legislature doesn't want to promote telehealth. I think it's the parity thing that was controversial.
I see. Thank you for that clarification. Appreciate that. All right. Any other comments? All right. Chair Khan, it looks like we can move to the next agenda item. You may have stepped away. Michael, are you prepared? You can go ahead and please open agenda item number 7 to discuss the possible cost growth mitigation strategies.
Okay, thank you, Melinda. So we're going to pivot this conversation rather dramatically right now. We, if you can think back to the last meeting, had 2 presentations that examined what was driving healthcare spending growth. And the reason that we're doing these cost driver analyses using claims for Medicaid and PEB, and the reason that we're going to start shortly collecting benchmark data from payers is to identify what's contributing to healthcare spending and lack of affordability. And with that information, to recommend policy steps that will slow spending and improve affordability. And these policy steps I refer to as cost growth mitigation strategies because we're trying to find some ways to slow historically high rates of spending growth. So for today, I want to give you just an introduction to this topic. We've not talked about this before. I think this will be and should be a recurrent agenda topic going forward. And in fact, in future years, when you're having BDR discussions, there might be an opportunity for you to consider BDRs that are specific to cost growth mitigation in order to address the specific drivers that come out of data analysis. So that's my context for this topic. So I want to remind you that during our last meeting, we reviewed spending data for Medicaid and PEB. And what we've heard from the presenters was that per capita healthcare spending growth has been far, far above median wage growth in the state and state economic growth. So you can see here 5.5% annually for Medicaid between 2016 and 2019, We had a shorter measurement period for PEB, an incredible 13.5%. And this is in context of wage growth. Now, the time window here is obviously much longer, 2002 to 2020, but 2.2% is obviously far below what healthcare spending is growing at. And that means that for workers, that healthcare spending is displacing wage growth because employers are putting money into healthcare benefits rather than to wages. And the fact that spending is eclipsing state economic growth means that increasing amounts of state taxpayer dollars and of employer dollars are having to go to pay for healthcare services. So that's one thing we learned. We learned a few other things. Two, we learned that healthcare spending growth was highest for pharmacy, for Medicaid and PEB for this time period. There were also some differences, though, between the two programs. Hospital outpatient spending was high for Medicaid, and professional spending was particularly high for PEB. Again, these, particularly the PEB analysis, was for a rather short time period, just a couple of years, but there are beginning to emerge from these initial analyses that we have the ability to identify cost drivers. And I will say that as Medicaid and PEB enhance their ability to report on spending patterns over multiple years and can do a deeper dive analyses, which they are planning on doing, we will understand better what is it about pharmacy, what is it about hospital outpatient services, what is it about professional services. And with that knowledge, you then will be more informed to be able to recommend action steps to address the cost drivers. But it was apparent that there are some services for which spending was growing more than for others. And then a third.
Michael, can I speak just for a quick question on that? Because especially on the pharmacy, I think it's important to know, without taking into account rebates, that number, the net cost of spend goes down. And I just want to make that clear because we really need to understand as a commission what the actual net cost is. So I just put that out there. And I am grateful that as a commission, we, in the last, as we voted, we are including that. So for the commissioners that weren't on before, we did include the inclusion of rebates and discounts in that number. So I think it will be important because that will be in the analysis going forward, and it will be more reflective, I think, of the actual cost in that category. So
yeah, so yes, thank you, Flo. The data that we're going to collect for the baseline benchmark analysis will collect rebate information for both commercial and Medicaid payers. And so when we're calculating trend for both, for each of the years, we will have net out rebates when we calculate trend. Babette?
Thanks. I do think, I'm hoping in the end, I know I raise this every time, to Flo's point, once we get those out, I mean, the further we can drill down into understanding where the cost increases really are, the better, because prescription drug prices are still increasing. And the rebates, if you take the rebates completely out of it, you still have some pretty scary price increases. So it'll be good to see. Thank you.
Yeah, we'll be able to show that. And I can let you know that Kyra Morgan for PEB, for Medicaid, is planning on some drill down analyses into pharmacy spend, and Laura's new contractor will be doing the same for PEB. So we'll have more insight than what you obtained at the last meeting. The other insight that we gained from that presentation is that where spending growth is highest, generally speaking, it's because of growth in prices, not growth in utilization. Okay, and this is across the board over all those service categories. That was one of the trends that we saw. That didn't mean that utilization was flat or declining, although sometimes it was, but the greatest inflator for healthcare spending appears to have been increases in prices. Or really, to be honest, payments per unit of service, because that's really what was being measured. So I want to be clearer there. right? So there were some initial insights that you got using, actual Nevada data that looked over multiple years. We certainly want to build this out further, and we'll get additional insight when we collect the benchmark data, but you are beginning to get some insight into what's going on. Okay, so I want to let you know that we shared a condensed version of what you saw in April with the advisory subcommittee, and they made some recommendations. They are advisory to you, so we want to make sure that we convey them to you. First, they recommended a price study be performed to better understand the role of price growth in driving overall spending growth. And I think it is our plan to bring more insight into what's going on with price. Two, there was a suggestion or suggestions to perform root cause analyses to better understand unnecessary utilization in Medicaid. I want to observe a couple things here. One is, as I noted earlier, it wasn't utilization growth that was driving spending growth as much as it was price growth, but that doesn't mean that there might not be levels of utilization that are potentially avoidable or unnecessary. Okay, so price was the driver, but we shouldn't assume that the base spending is appropriate and high value in all cases. So these were the two recommendations that really related not to cost growth mitigation strategies, but further analysis to understand the data that was initially analyzed. Leanne?
Thanks. So I watched this meeting. It was really interesting. But after the meeting, I went looking and I couldn't find anywhere a published list of the members of the advisory subcommittee. So I guess I have a request that that be added to the Patient Protection Commission website.
Okay, thanks. And thanks for joining the meeting. So what I want to share now is strategies that other cost growth benchmark states have started to use to address spending growth. And this is just for education. I'm not recommending any of these, but as you begin to think about how do we address those cost drivers that you had presented to at the last meeting, I want to give you some idea of what other states are doing. And I'm focusing specifically on the other states that have cost growth benchmarks, because they're all pursuing a similar strategy of setting a benchmark, measuring performance against it, doing drill down analysis to understand cost drivers and cost growth drivers, identifying opportunities, and then advancing strategies to slow spending growth. So I'm going to give you a little overview of these, and please feel free to interrupt me and ask me questions at any point in time. So in no particular order, the first one is market consolidation. So market consolidation is when you've got healthcare entities combining into one corporate entity. There's both vertical consolidation and horizontal. So a vertical consolidation would be when different types of providers come together, such as hospitals buying physician practices, which has been common across the US over the last decade. Horizontal is when you get two like entities that are merging. Okay. Why do providers merge? Well, they do it for many reasons. One is it gives them increased negotiation power with private payers. There can be some gained economies of scale to offset fixed costs. And there might be a way to just limit general economic risk by diversifying your service portfolio. Okay, so these are the potential reasons why it's pursued. There is growing, and I will say robust evidence nationally that that growth in healthcare costs are mostly due to pricing increases. So what we saw last month is not specific to Nevada. In every single one of the cost growth benchmark states where I'm looking at their data, I'm seeing the same thing, that it's price. And there's tons of evidence showing that market consolidation leads to price increases. And it's because there's increased market power. Now, obviously, this doesn't happen in the Medicare and Medicaid markets as well, where the government purchasers have a lot of market power themselves to dictate prices. But in the commercial market, it dramatically results in increased prices. Okay, I'll also note that evidence on higher healthcare costs don't show any improvement in the quality of care or patient outcomes. Okay, and there's, again, lots and lots of evaluation on this. Babette?
Hi, I wanted to just mark this. We tried to do some legislation about this last session, and I would love if, in addition to these findings, we had follow up on what are other states doing about market consolidation, because it's a huge issue and it's hard to tackle. And I'm hoping that you have some suggestions for that, because my brain is in the commercial market.
Yeah, so for all these strategies, I'm going to give you 1 or 2 state examples from the other cost growth benchmark states.
Okay.
Okay. And this is all introductory. And again, I'm not making any recommendations. I'm just sharing what are other people doing. So
well, Michael, as long as I'm still talking, that second slide where we have the 2 bullets where the advisory commission made recommendations, are we going to vote on that, or do we just automatically assume that's happening? Because I think those are good recommendations.
Oh, please weigh in. You're invited to comment on it. I don't know that you need to vote on it, but you can express your support if you think.
Okay, I'm expressing my support. I hope we have a process to accept them as a board. Thanks.
Okay, so an example of market consolidation, and I think I listed 3 states, Washington and Connecticut as well, but Oregon is doing this in a big way. So they passed legislation last year to oversee what they term material change transactions. And so this is all to be performed by the Oregon Health Authority, which is sort of an omnibus health agency in the state. And you can see here, they are required to review, and they have the authority to approve or reject transactions that meet these qualifications. So you'll note it's transactions of any healthcare organization. So some states, such as Connecticut, have requirements, but they are limited to certain types of organizations. They might be restricted just to hospitals. This says any organizations that are large enough to meet these financial parameters will be reviewed by the health authority, and they can say yes or no.
Michael, does this include insurers and their relationships with like pharmacies and their relationship with PBMs?
I'm not positive, Flo. I think the answer is no, but I'm not positive.
I would just suggest, if you are going down this path, that you should look at all of the healthcare system, and those would be entities that should be included as well.
Yeah, well, so I'm just disclosed. I'm not going down any path. I'm just giving you an example of in this case, what Oregon's doing. Just so you all are aware that, one of the strategies states are taking, because market consolidation drives up price, is to try to limit future consolidation. Nobody is trying to undo past consolidation, and some people will argue, well, the horse is already out of the barn. But there's a fair amount of state focus on trying to limit future consolidation that could have an inflationary impact. I know that that just recently in Massachusetts, the biggest health system in the state wanted to put up a whole bunch of, I shouldn't say a whole bunch, at least 2 or 3 large ambulatory care centers in the central part of the state, and ultimately their request to do so was rejected because there was analysis that said this is going to contribute to healthcare spending growth in the state. So just, there are states like Oregon, like Massachusetts, that are taking actions to try to limit that activity. Anybody else have any comments or questions about market consolidation? Okay, so this is strategy number 1. The next one is price growth caps. So these set a limit on how much a health insurer can annually increase the prices that it pays for a service. Again, this is a commercial market strategy. This is not rate setting. It also doesn't address prices that might already be high. It simply is limiting the annual increases in rates. Now, I will say that there's another strategy that I haven't listed here that has not been broadly used, although Montana used it and Oregon used it with their version of PEB, which is to set price caps, which is to get at outlier prices. But that's not what this is. This is a price growth cap. It can be structured in a few different ways. It can apply to the market basket of all of the prices paid to a provider, or it can be specific to individual services. It can also vary so that you have a price growth cap that is higher for lower paid providers and lower for higher paid providers. Although there are no operative examples of that right now. It's been discussed elsewhere, but nobody's actually done that. So what this can do, again, is to limit market power that otherwise pushes up prices. But it does not dictate the payment methodology. Okay, this is similar in concept to the cost growth benchmark in that cost growth benchmarks don't say we should reduce spending or it shouldn't grow, but it tries to limit the rate of growth. That's what this is doing. But it's implemented using regulatory mechanisms. So it's stronger than our cost growth benchmark is right now. Tiffany?
Just want to confirm, in your preliminary analysis indicates that price growth is a major consideration or impact currently for us.
Yeah.
Okay, thank you.
Yeah, those are what the data that were presented at the last meeting showed. Okay, so that's why a strategy like this has some relevance. So there are two states that have done this so far. Rhode Island was the first. They did it about 10 years ago. They have an office of the health insurance commissioner, and they established regulations that require that commercial insurers have to adhere to certain affordability standards to have their premiums approved. And specifically, they put in place a price growth cap. And it says that prices cannot increase for inpatient and outpatient services more than the Medicare price index plus 1 percentage point. And this was an intervention that was actually evaluated by some academic researchers, and they published a paper in the journal Health Affairs in 2019. And they found that Rhode Island's implementation of their affordability standards, and I would say principally the price growth cap, reduced per commercial enrollee spending without impacting quality as compared to other New England states. So they use the other New England states as a control group. The other state that's doing this, yeah, Tiffany, you have a question?
It's a related question. Do you recollect any of the BDRs that we have reviewed or proposed addressing this price growth issue or supporting this type of infrastructure if we were going to target it?
Not in the batch of 17.
Okay.
Okay.
Can I add some comment to that though?
Sure.
I have two comments. One is, I think, thank you for asking that question. I had the exact same thought about we should see this material before we introduce BDRs, because these things you're talking about are solutions. But I think that we did try to do a competition bill last session, not the coalition, our coalition, not this commission. But to your point, it's a little bit that the cart is, the horse is already out of the barn. And so trying to put a limit on some of the consolidation is something that the state of Nevada is starting, but I would really like these ideas here to be put into BDR options for us. Specifically on the list is this idea that we need to make sure the corporate practice of medicine is enforced in Nevada, because what that is right now, doctors, if they get hired by a facility they're not supposed to be, but it's happening, that doctor then is taken out of the pool of available physicians in our community, that he will not now be able to do heart surgery at all the hospitals because he works for one hospital. And that not only reduces our provider pool, but it drives business into that one system. And so we have this law on the books, but it's been very vaguely interpreted. So that's one opportunity on that list of 17. And then previous legislation last session is additional that could be, beefed up, and then these as well. So maybe this is raising a conversation about another way to look at the BDRs.
So, Bobette, this is Commissioner Dr. Khan. You bring up an important subject here. And I think we need to collectively think of other options very closely, because sometimes we get into a situation and we have unintended consequences. So we need to really thoroughly look at it from a not just a legal and legislative point of view, but from a practical point of view also. How does one make it work or stick or get done properly so that we have covered all bases and not suddenly find out, oh, by the way, we could have done it this way, but it's too late for that. So that's my only comment on that. Any other comments?
See, Tyler has his hand up and Flo just raised hers.
Well, thank you. So I want to say, I think it was very good that we spent the time we did reviewing the BDRs that we did, and I'd like to do that process with the other BDR submissions, because I did submit for affordability review boards for drug pricing and for commercial health plans. So it would have been nice, now that we're bringing it up again, that we could check into those BDRs and see if there's other things we missed as well.
Thanks, Tyler. Flo?
Yeah, so I have a couple questions. First of all, Bobette, I have a question to you that you just raised on, there's doctors that are being pulled from a system inappropriately. Can you explain that to me?
Sure. I don't want to distract from this entire thing, but I did want to just flag what Tyler's flagging, that there are some issues in the 17 BDRs that would help just for some of these cost issues that we're seeing. There is a corporate practice of medicine law in Nevada, which says that physicians can't be hired by hospitals or facilities. But it was tweaked when the Nevada Cancer Institute came. They wanted to be able to hire physicians directly for their facility, and that was approved by the legislature and it opened the door for some nonprofit facilities to be able to do that. And it's really important that a place like UMC that does all the trauma care be able to do that. So there is a need for some specialized hiring, I think, at the public nonprofit level. I think Commissioner Van Helling, you might have something to say about this. I should not try to pretend like I'm a hospital executive, but that has been misinterpreted by other hospitals, or intentionally or not, where physicians are being hired by a facility and it literally takes them out of the pool to take care of patients at other hospitals. And it also makes that care less available at the hospital because we have such a limited, pool of specialty physicians. So the law is murky, and I would just like it clarified. And it's one way to help limit the impact of consolidation by making sure these physicians stay available to the whole community, with the exception of the public hospital that has always had that exception.
All right, thank you for that clarification. With respect, I just have a question to Michael on some of these. When you talk about limiting the provider rates, what we have seen is that, and so I guess the concern, and we talked a lot about this last, the commission last year, or as we were looking at BDRs last year, in terms of Nevada's already at the lowest rate. Like they have some of the lowest provider rates. And if you lock them into a rate and then you only allow for a little limited amount of cost growth, how is that going to exacerbate your problem with providers and attracting providers within this state? I'm just asking, because that's a concern I think we raised earlier, or the previous commissioners raised, who are, more affiliated with providers and, these groups. So I'm just curious how that would play out under a scenario like this.
Mm-hmm. I mean, you've got twin objectives. You want to have a robust provider network, but you also want affordable healthcare. So the cost growth benchmark is about slowing healthcare spending growth. So this strategy is about a tool for slowing healthcare spending growth.
But if you don't have providers, I mean, what's the
well, I know. So you've got twin competing objectives, but the governor's executive order is to slow healthcare spending growth. So I'm just sharing what are strategies to do so. I understand the concern about needing to attract and retain providers, but I'm just laying out strategies to slow spending growth. Babette?
I would just like to add to what you just said. I think the spending growth patterns that your data is showing and our data is showing, the price increases are more related to facilities and hospitals and prescription drugs than they are to doctors. So I would say that this commission has the ability to navigate which kinds of healthcare we want to promote cost control on. And it may not be the providers, maybe the other segments, the ones that are growing so much more quickly.
Problem with price, anytime you get into this, and we can talk about the drug affordability board, all of these price controls, they limit access. They do. And you may not want to believe that, but that's the reality. And so you have to be very careful about price controls. And I would also just argue, and I mean, I know we're not on that yet, so I'll actually wait till we get there. I don't want to hinder our ability on this.
Right. I will say, only because I've been working in Rhode Island for a decade, that a lack of access to services has never been identified as a problem from their price growth cap.
And Michael, if I could really quick, I just wanted to note in the chat, as was discussed previously with a few other commissioners, Commissioner Tyler Garner is supportive of reviewing and integrating preliminary findings and solutions into our BDR process. So just wanted to note that. Thank you.
Thanks, Melinda. So the other state that's pursuing this strategy is Delaware, and they pretty much are carbon copying Rhode Island. So in 2021, they implemented affordability standards. They almost look exactly like Rhode Island's. They set their price growth caps a little bit differently. You can see them stated here. Instead of using the Medicare index, they're using core CPI, but the concept is similar. And they're just to implement this now.
This is Dr. Conacook. Just keep in mind, one size does not fit all. That's my personal opinion. Number two, Nevada has always been different in many, many ways from other states. While it's good to have a working paper or document, whether it's from Rhode Island or Delaware, one needs to carefully look at it. And if it has to be customized to the situation and market in Nevada. There are many, many dynamics which are different from some of those states that you're mentioning, or even other states in the country. So one needs to take a close look and make sure that we have areas covered based strictly on our market situation, whether it be Medicaid products, private sector products, managed Medicare care products. So one needs to look at that very carefully before we say, because so-and-so state did it, so we should be able to do it.
Thank you, Chair Khan. The third area is prescription drug pricing legislation. I could do a much longer presentation than I'm going to do for you today, but I just want to make you aware of what other states are doing. There are multiple states that have tried to introduce legislation, some successfully, many not to date. There's lots of active lobbying whenever such legislation is introduced. Some states have tried to increase drug pricing transparency through reporting and notification. Some have attempted to institute some form of price control, including fines for unsupported price increases, benchmarking or referencing drug prices, and establishing affordability review boards to have a more active role in reviewing drug prices in the state. There are lots of analyses that show that prescription drugs are a main driver of cost growth. You saw it last time. It certainly is one for Nevada, but it is in other states too. This is not a state-specific issue because drug pricing isn't local. So a couple of state examples. The Connecticut and Massachusetts governors introduced legislative proposals last year and again this year to impose financial penalties on drug manufacturers for excessive price increases. They said at CPI plus 2%, and a penalty would be 80% of the amount by which the drug's prices exceeded the benchmark. Rhode Island also copied it, and their version of the PPC recommended that the governor pursue similar legislation. He did not act on that recommendation. I will note that he had just he had just assumed the office just a few months earlier, midterm, so that might have been a reason why. There are other types of legislation, such as reference pricing, where states reference the prices in Canadian provinces. That tries to, rather than set a retrospective penalty, tries to do something prospectively.
And I would just add, like in Connecticut and Massachusetts, those, you're correct, have not gone anywhere. They have both failed for reasons, we can go into a lot of the reasons why. But mostly I would say, Michael, I think, and again, we need to look at this across the board. And as you said, nationally, drug prices have gone up. But in fact, when you look at the data, when you take into account the rebates and discounts, drug pricing has stayed relatively flat. Now, there are outliers. I will absolutely agree there are outliers. And so you want to look at, certain states and certain, there's different reasons why it could happen in a particular state. But overall and nationally, the data shows that it hasn't grown significantly.
So that's not what we've seen in the data that we've looked at, even netting out rebates.
So I would just say, we would like to, explore and show data that does show that. I mean, we've got data that does show that.
Well, we're going to have it for Nevada.
Who's we flow?
The industry.
Right.
But it's data that's collected by the CMS. It's not our data.
But we're going to have it for Nevada specifically because we just asked the insurers on Monday to submit their data to the state. And so by later this year, we'll have information and we'll be able to tell you what pharmacy trend has been across Medicare, Medicaid, and commercial markets.
I agree. So I think it will be really helpful to see.
Yeah. Tiffany, then Babette, and then Beth. Yes, no? Well, we'll see. Tiffany.
Thank you. Just a quick clarifying question. There was some previous discussion about pharmacy as an area and its growth. Now, there's two items related to this discussion. And is this a proposed strategy for mitigating the area where we have seen disproportionate or significant growth?
The data that we have suggests that pharmacy spending is contributing to the affordability problem in Nevada. It's not the only cause, but it is certainly a significant contributor. And just to give you all some perspective, pharmacy spending in the commercial market, especially if you include medical pharmacy, which is the infusion drugs, it's over a quarter of total healthcare spending. It's not a small fraction. It's a huge amount of healthcare spending. So, I mean, I'm just sharing with you what other states are doing. I'm not making a recommendation that you do anything, but it's not a coincidence that there are a whole bunch of states that have tried to advance legislation around prescription drugs and prescription drug prices. It's because it's a big problem in lots of states, including the other cost growth benchmark states. Babette?
I just wanted to add a little to that. Thank you. I think in response to Commissioner Khan's comments about the efforts to date haven't gone anywhere in other states. In Nevada, we worked really hard to pass the first insulin transparency bill. in 2017 or 2019 and followed that up with asthma. And then it followed that up with more transparency work in the state of Nevada. And the reason these bills don't go very far, there's two reasons. The number one reason is the pharmaceutical industry claims that we're infecting interstate commerce and files lawsuits. And so laws that have been passed have been challenged by the pharmaceutical industry. And so we have limited scope in what we can do to actually price set, which is, what many people would like to do. But there is additional work that we can be doing in some areas of transparency, and maybe these boards are one option. I just wanted to make it clear that it's not for lack of trying that these bills don't get as far as they need to. There is active opposition.
Oh, yeah.
It's passed.
And lawsuits.
Nevada, you've passed transparency on the industry for all of those, for all the drug classes. It's passed. Yes. It's in effect right now.
Yes, I know it is. And this is after the lawsuit that we had to defend that pharma created a couple of times when we started transparency work.
No, we were not, well, we can go into this. We were not
opposed. Yes, we can. I'm happy to go into it.
We were not opposed to transparency.
Flo, I think we're following an order of people raising their hands. Beth.
I just wanted to add on to, what Bobette stated in terms of the transparency work that's, happened within the state. Besides some of the restrictions in terms of the data that we receive, and the information that is reported in aggregate, not down to the drug level. We also have roadblocks in terms of the claims information and utilization that we have access to. And so a lot of the transparency work is limited to, Medicaid claims information, which is just a very small portion of the state. And so it doesn't, create a complete picture. So I think all of those things, have impacted some of that work. I think what needs to be recognized, I appreciate all of this being brought forward as what other states are doing. It is all very labor intensive. I can tell you that from personal experience. And so that needs to be recognized when we're looking at these things, that, the resources need to be there, the data access and availability needs to be there, so that we can create those complete pictures and we can actually develop policy that's meaningful. And that's not where the state has been, especially in terms of prescription drug pricing. And then just another note, on the transparency work and in regards to some of the conversation that's taken place, we're getting ready to put out the next report, the state, June 1st for the transparency work. And I can tell you that what we've seen in terms of especially the Medicaid utilization, even with COVID and all of its impacts, the utilization, might have doubled, but the cost of the medications and the impact from a fiscal standpoint is over 100%. So, the prices have definitely gone up exponentially to what we've seen in terms of utilization. So it is most definitely an impact to the healthcare costs to the state.
So quick comment. Is there somebody else ahead of me?
No. Go ahead.
So there are several areas that one could at least look at, and I don't want to put anybody on a spot, but perhaps Bobette from the managed care industry has some insight into the cost of medications, and Commissioner Van Holling from the hospital side, the cost of medication. Those are the two areas that have probably the most information that could be valuable to do something about it. And Bobette, if you want to answer, and Mason, if you want to also give some input, that would be helpful for the commission to understand how this is impacting patient access and patient care, rather.
Well, I think that you've seen we've been very involved in trying to get transparency on the books in Nevada and then fight these pharma lawsuits about it, claiming that transparency is that prices are a trade secret. And I think that, we can come back to that as a board, as a commission. But I think, yeah, we've definitely seen pretty extensive price increases, even when you take rebates out. And I will go check if there's data that we can provide easily to this commission.
Yeah, that would be
And
helpful.
I would want to make sure we don't get sued by pharma in the process.
Yeah, well, we have to start something somewhere, and if it gets blocked, it gets blocked. So it won't be for lack of trying. Mason, you have any input from the hospital side on the cost? I mean, I know a lot about that also, but you know it more firsthand.
Sure, Chair Khan. Well, in the hospital industry, typically labor is our most expensive line item. Obviously, our people are our most important asset, especially with wages and the shortages that we've addressed earlier. And then second comes supplies. And then within supplies, there's a lot of things, especially with the PPE and other things that have been challenged with sourcing. The pharmaceutical side, obviously, there's heavy research and science that go into innovation and technology and therapeutics. And we saw a lot of that during the pandemic happening very rapidly. Obviously, hospitals, we always like when things go from IV to PO or brand to generic, and that happens through the cycle of pharmacies. But I think the biggest challenge for us right now, and I'm sure we'll have asterisks by everything from 2020 to 2023 and supply chain issues. So, but it's obviously we need to make sure we get the data right, and UMC is uniquely positioned to get 340B pricing. So, which is an advantage to our organization that provides so much uncompensated care and charity care to the community, and that certainly helps replenish the pharmaceuticals that we provide, not only at UMC but all of our ambulatory clinics within the Valley. So it's a program that we're very fond of because it helps us cover our costs on providing the services that we do. But it's definitely up there. And then I think back to one of the things that somebody had mentioned on the Medicaid state budget. Looking at the last presentation, Nevada Medicaid is the highest insurer in the entire state. I think we need to be very clear on that. So we need to make sure that Mr. Whitley is able to balance the budget, and as we continue to see more people come to our state from other locations, we need to make sure that it's there for everyone that needs it.
Thank you. Anybody else have a comment?
Sarah?
Yes, I just actually want to weigh in, as one of the patient advocates on this commission now. I can't help but feel like these conversations are incredibly important. It's necessary, but it is uncomfortable on the patient side when you're talking about pricing and resources. I think what we need to do is pause and remember that we should be having a discussion about maybe treating healthcare not as a commodity, but as a right. And some of these discussions, when you hear about it and you hear about resources and pricing, the patient gets caught up in the middle of it. And, when you talk about one of the things that's not being discussed really is a discussion about the profitability. And I think there could be an argument that there's a lot of profitability in the healthcare world that exacerbates the access issue. So one of the reasons why we're talking about pricing and healthcare spending is to address the access to care, particularly for the patient costs. So I would just regret not speaking up on behalf of patients as we're having this discussions, and really just ask this commission to keep in mind that we need to have the patients at the forefront of these discussions, particularly keeping in mind that I believe healthcare is a right and we shouldn't be discussing this as a commodity. That's all.
Any other comments?
Flo, raise your hand.
Yes, thank you. And Sarah, I think that's a perfect point, is that we need to be taking the patient into consideration, and more we're seeing costs being placed on the consumer for all products, for all services, but particularly with prescription drugs too. They're having to pay more out-of-pocket costs as we have changed insurance benefit design. And that's true. You've seen patient cost sharing go, it's raised over 150% or more often. And so they are having to come out of pocket more and more. And so that should be the number one concern. I agree with that.
Okay. Any other comments? If not, you can continue.
Okay. So the last strategy that I want to share that some states that are cost growth benchmark states are pursuing to improve affordability have to do with payment models and specifically increasing the use of advanced value-based payment models. So by value-based payment, I mean paying for healthcare services in a way that integrates in financial incentives for greater efficiency and improved quality and outcomes. Value-based payment models are sometimes referred to as alternative payment models, or so the two acronyms here are VBP and APM. And I want to share with you a little bit about this concept. So this is a diagram created by the Learning Action Network, which was funded by CMS or through CMMI. And it lays out a continuum of value-based payment models. As models move from the left to the right, they move away from having fee-for-service payment as a foundation. And fee-for-service payment is inherently inflationary because you get paid more for doing more. So there's an incentive for doing more, whatever doing happens to be in this case. And so as it moves to the right, it moves away from that fee-for-service chassis. And I would say in general moves towards more budget-based payment models. So the rationale for pursuing value-based payment as a method for improving affordability is to strip out the incentive for volume and to create meaningful incentives for efficiency and quality. Right. So that's the general logic model, and through this, hopefully helping the healthcare delivery system get on a track where it sustainably is going to attain the cost growth benchmark. So I've got a couple of examples. Oregon in October of 2020 had their version of the PPC create a set of principles to spread the adoption of advanced value-based payment models in order to hit their cost growth benchmark. And they ultimately established a compact signed by 47 organizations that I think altogether represent something like 90% of the state population. It was a very high percentage. And so they all were voluntarily committing to adoption of value-based payment models. They then created a work group to think through how to implement the payment models, because they had established some milestones to be hit over multiple years. So this value-based payment work group began meeting probably early in 2021, I would guess. And they just are putting the finishing touches on a roadmap that calls for implementing some new payment models in the state, including moving towards hospital global budgets. So a hospital global budget is a prospectively set budget. It can be also with prospective payment where you've completely untethered from fee-for-service payment. So that's an example from Oregon. Rhode Island, coincidentally, decided to adopt the same strategy. And they created a value-based payment subcommittee of their governing body, or their PPC, last summer. And they, in April, came to agreement and executed a compact as well with 3 payment models. Also hospital global budgets, inclusive of employed professional services, prospective primary care payment, and prospective payment or episode-based payment for selected specialties with significant independent practice volume in the state. Okay, so 2 states that have decided that changing the payment model in a big way, not at the margins, is a way to help them attain their cost growth benchmark. Any questions or comments about this, about value-based payment or either of these 2 examples? Babette?
Thank you. I know I'm speaking a lot today. What I'm struck by as you go through this presentation and the discussions about that the patient has to pay a high portion of the cost, I think we are like not actually accurately talking about the price. Cost is not the price. The cost of care is not the same amount as what's being charged for care. The prices of care are exorbitant and becoming more so in healthcare. And that's, to Sarah's point, this is why we even started this cost growth project, but I really think we should be talking about profits. So is there anything that you've seen, Michael, or anything in the work so far, or any examples where we're actually trying to get to the cost of care and have a percent of the cost of care be what we work on, instead of just trying to mitigate profits, which are an increasing portion of the price?
So when you say the cost of care, you mean the input costs to the provider organization? I'm not sure what you mean by cost of care. Is it what the patient pays, or the input cost for the provider?
Like the cost of what it actually costs to provide the care. Like Medicare has the Medicare cost reports that show in a hospital every year how much the care actually cost versus what the cost versus what they're charging, right? The cost to charge ratio is something you can measure in a hospital. I don't know if we can. I think we could probably measure it in prescription drug industry if we had more data about the cost of Medicaid, the actual cost of producing medication, but that's cloaked by trade secrets. But if there's a difference between what it costs to provide care and what is charged, and the profit is in there. So if we were going to try to mitigate the impact of cost, it would be by tackling profit. And I don't know that any of these presentations or any of these initiatives actually do.
So organizations, the other states are not focusing on input costs or margin, in part because there's a relationship between the output price that's paid and the cost. In that the more you can get paid, the higher your cost can be. And we've learned that over time. So provider input costs often rise to as high as the price they get paid allows for. So you get into a little bit of a circular argument. So I would say no, there are no states that have said we've got to think about a way to lower input costs, because they're really focused on the price that's resulting at the end, knowing that if they can find a way to slow its rate of growth so that it's not outstripping wage growth or state economic growth, that the organizations that are charging the large price increases will find a way to manage their costs within what the prices are going to be. Does that make sense?
Yeah, so there's an assumption. It does make sense. I guess I need to understand how you're defining input. So input is how much they're charging. Input isn't how much care costs.
No, input is how much care costs. So it's Mason's wages and supplies. Those are his input costs. Ultimately, he's going to be paid a price by a payer, but his input costs are wages, supplies, whatever else goes into running the business. And I'm saying what states are not focusing on that. They're focusing on trying to control the payment that's coming out at the other end.
Yeah, and if you can control the payment as a relationship that it has to profit, then you're providing all the care, covering all the costs, getting the supplies to Mason, making sure workers are paid, but you don't have as much profit on top of that is driving the private equity market to try to take over healthcare. You're controlling. So we need to know the difference between what care actually costs.
But one of the reasons that the profits are high because there's the ability to raise prices.
Right, endlessly.
Right. So if you constrict the ability to raise prices endlessly, then any excessive profits that anyone might be garnering they're not going to be there over time. And I'm not saying that there are lots of providers earning excessive profits, but what I am saying is that if prices rise, then it allows organizations to increase their costs. So it actually might look like the margins aren't that great, but it's because they're funneling the added revenue into their base costs. Anyhow, we have 3 hands up and time is ticking. So Babette, I'm going to go to Tyler next.
So just because you brought it up, I wanted to make the point that states aren't focusing on payments by, I don't know, as like an ideological thing. It's just this is how the cost growth benchmark is designed. It only focuses on the payment side, what payers are paying. And I'm kind of getting ahead in the slide, but I think the next point is what we've seen, what kind of things do we want to consider. But I think the information that we've gotten from the phase 1 analysis, because it is lacking everything that we've defined as a total healthcare expenditure, including profits, including costs, all of those things, non-claims based payments, I would like to have more confidence in what our actual healthcare cost rates are and all these things. I think you're right. We're definitely able to see that the prices get raised, but I think it's incomplete and it's hard to make a recommendation on how to tackle it without that. So thank you.
Thanks, Tyler. Your lady?
Yes, thank you. So listening to Commissioner Bond, I kind of understand it in the way that if we can limit the percentage of profit that these healthcare organizations are getting, we could limit the price or the cost of healthcare that gets passed down to the patient. Is there a way that Nevada could do that? Limit the percentage of profit that the healthcare organizations are getting as our benchmark.
So you can do that. I mean, I'm certainly not going to tell you all what to do, but I have seen very, very expensive healthcare organizations that have small margins. Okay. So I think if you focus on the margins alone, you're not necessarily going to slow healthcare spending growth. Because what do they do with the excessive margins? They put it back into the business. And so instead of saying we're going to have this be a margin, instead we're going to increase the wages for our workforce and give everybody a giant bonus. So then it shows up as a cost. It's not a margin.
What about the shareholder that gets the,
Yeah, it's for for-profit.
That's not part of it.
Right. For for-profit entities. But, still a lot of the healthcare delivery system is nonprofit.
Not in Nevada.
No, not at all.
All the hospital systems in Nevada are for profit or publicly traded.
Okay. Leanne.
I just didn't want to let this conversation pass without bringing up concerns we do hear from patients that while they understand that there's a value-based focus that you only, don't want to pay for volume, you want to pay for value, that there might be a hidden incentive to not treat very sick or very poor patients. And that then and maybe we need to clarify between VBPs and ACOs, but that if the ACO is being incentivized to control costs, well, then who wants to take care of really sick people?
Yeah, well, I would say it's how you structure the payment to the ACO. You can pay them so that they are not incented to not treat sick people. All right, so Tyler was getting me to my next slide, my wrap-up slide. So you've heard from the phase 1 cost driver analysis. You heard it last time. I summarized it for you at the beginning of my presentation. I shared with you a little bit of input from the advisory subcommittee. And I've shared with you some strategies that other states are pursuing. Certainly there are others. I'll note, by the way, some of these strategies other states are pursuing precede their cost growth benchmarks, right? So they started working on some of these strategies before they established a benchmark. Some of them they initiated afterwards. It's a mix. So given what you've heard, this is just a first conversation. We're going to talk about this a lot over time. Do you have any reactions in terms of areas where you have interest? It says here for future consideration. Future consideration means probably learning more. But is there anything we've talked about where you would like to learn more and dig more deeply? Tiffany.
I'm hopeful that a number of the areas that we articulated in this conversation might be identified as something that we might explore more. So several of you have noted that there are some potential considerations or implications that we have not explored, but that absolutely inform what we're trying to mitigate. I'm hopeful that a few of you will memorialize that as a request during this portion of the conversation. Thank you.
Thanks, Stephanie. Babette?
I would agree with everything Commissioner Tyler Garner just said. I'm hoping that our Executive Director, Melinda, that you're capturing sort of the conversation here, because I think there's a lot to follow up on. I would like us to specifically figure out how we find out more about cost and versus profit and what measures are available for that besides the cost to charge ratio and Medicare, which I think is a conversation we should add to here at this. And then I would like to go back to those 2 bullet points on that second slide and have a motion that we're going to accept those advisory panel recommendations. And then I think that if there's suggestions of BDRs that could help address some of these issues where we're going to get to a better relationship between cost and profit and price, we have a chance to go back to the BDRs and add those. Those would be my requests from today.
Thank you, Commissioner Bond. I did just want to know, I do have like 3 pages of notes, so I am fully taking down notes on everything. Thank you.
Leanne? Any other comments on this?
Yes, this is Leanne McAllister. So we learned in the last meeting that one of the cost drivers for the commercial side was cardiac care. And I would like to know some more about that, if that's unique to Nevada or not.
Okay.
I'm sorry, you cut out. I didn't hear what you said.
In our last meeting, in the analysis that was presented from the commercial data, that Nevada has seen a significant increase in cardiac care spending. And I didn't know if that was unique to Nevada or not.
So you heard the funding request that's going to go to Peterson from Melinda earlier, and that included analyses to drill down into spending by health conditions. So hopefully we will learn the answer then.
Wonderful, thank you.
Mm-hmm. Tiffany, did you raise your hand again, or is it up from before? No? Okay. Babette?
Yeah, I raised my hand again. The RAND 4 data just came out that is a pretty good national benchmark for what's going on with hospital care and the impact of the commercial market, which Commissioner McAllister just raised, versus the public market. So I think it would be wonderful if we could add some summary of that or an extract of that or include that in some of the data that we're reviewing, because it was just released.
Yeah, I think another option, if you're interested in looking at, is in particular for hospitals at cost versus profit, is to receive a presentation from the National Academy for State Health Policy. They have created a hospital break-even analysis tool, and they've presented it to bodies like the PPC in a couple of other states. I have not participated in those, but I heard that they were enlightening and well received. So maybe, Melinda, we can connect with them and see if they might be willing to do a future presentation.
That would be great.
Yeah, I had actually watched their webinar, and it was very informative, and I agree that would be excellent data to present to this commission. So I will follow up on that. Thanks.
Yeah, they're willing to do state-specific analyses and presentations. Tyler?
Just following up on that, I want to clarify that our benchmark data, our total healthcare expenditures, we will be able to see that profit and loss, the cost sharing as part of those plans, correct?
No. So we are collecting payment data. We will, so we're just seeing what did payers spend on healthcare spending, not on what were the margins that any providers earned on the spending. For that, you have to look at the financials.
Just to clarify, I'm referring to the payers, not the providers, because that is part of our healthcare expenditure.
Yes. For payers, we will get their admin and margin separate from the payments that they made to providers.
Yeah, so I do want to emphasize that the concern isn't just profits side for healthcare providers, but also for the payers, what our plans are making.
Yes.
Yes, thank you.
Really quickly, I did want to note in the chat, Commissioner Tyler Garner had mentioned she would love a deeper dive on cost data associated with children, particularly in the Medicaid data. And I believe that is going to be addressed in one of our phase 2 analyses as well.
I think are there any other comments? We are nearing the end of our time limit. So if there are no compelling comments, we can hopefully move on.
I see Commissioner Bond's hand is raised. Bobette, do you want to go ahead? Oh, okay. That was from before. Okay. I don't see any other hands raised, Chair Khan.
Okay, so should we wrap the subject up and move on to the next item?
So I just want to confirm with the group, Chair Khan. So I heard early on, Tiffany and Bobette express general interest in cost growth mitigation strategies, but I don't think that the PPC has said that there's aside from better understanding spending on cardiac care, on kids and hospitals, including profits versus costs, I haven't heard anyone express interest in a particular cost growth mitigation strategy area, at least today. Leanne?
Well, I'm sorry, I thought the question was that hasn't already been discussed. I mean, I am very interested in what the other states are doing to control drug costs.
Okay. Yeah, I was looking for, hey, of everything that you've heard, do you have special interest in any of these areas?
Yes, what other states are doing to control the growth of drug costs. Absolutely.
Okay.
Number one with the bullet is case of case, I'm used to say.
Okay.
And I would like to say that I also agree with that, the drug cost. And I would like to know a little bit more about the value-based care, moving away from fee-for-service.
Okay. Sarah?
I just want to throw it out there if I didn't formally express it, that I am definitely interested in having a discussion on cost growth mitigation strategies and what our state can do and what other states are doing.
Okay, but not in any of the particular ones that we shared today.
I agree with what all the other commissioners have said, and then I just want to get some more time to weigh in at our next meeting. I just didn't want to have my absence be an indication that there was no support. That actually it's opposite.
Okay, that's fine.
Any last comment, Bobette?
I'm just wondering, what you just said that, Michael, what would be helpful? What do you need to feel like you're getting a directive to pursue all of the cost growth mitigation strategies you introduced today? I think we need to learn.
Okay.
I don't think we should be ruling anything out. I think we should be pursuing it all.
Okay, so we can come back at a future meeting with a deeper dive into these topics to help you understand them better and their pros and cons and what would be involved in advancing them.
Okay.
And maybe not all of them in one meeting, frankly, because they can all be significant. But that's good to know that you all have interest in learning more about all of them. And that doesn't rule out introducing other cost growth mitigation strategy options too. I just want to know.
And additionally, I did want to note in the chat, Commissioner Winkler had mentioned he's particularly interested in affordability review boards for insurance and drug pricing, and does agree with the deeper dive into all of those strategies.
Okay, great. Okay, thank you. That's what I was seeking.
Okay, so we should move. I'll take one last comment. Is there any one last comment from anyone, compelling one? If not, thank you, Michael, for the presentation. So I think we'll move on to our next item, which is public comment. Back to public comment. Melinda, do we have anybody in the public comment section physically or online at this time, north or south?
Let's see, if you wish to raise public comment, please press *9 to raise your hand. And just looking through. I do not see any public comment.
Have you received anything in writing, even though it was late kind of a thing?
No, I have not received any public comment in writing.
Okay, so there are no public comments. I appreciate that. I think that brings us to the quote unquote wrap up and adjournment. So I think the meeting will stand adjourned for right now. And I really appreciate you all watching out for the time. Thank you as always. Take care.
Thank you.
Thank you.
Bye-bye.
Thank you.